Hello and welcome to this episode of ASNC Interview Series, where we have candid conversations with luminaries in the field about hot and controversial topics in nuclear cardiology. Today's episode is going to be no exception. But let me first introduce myself. My name is Firas Badarin. I'm a cardiac imager from Cleveland Clinic, Abu Dhabi, and I currently serve as the Vice Chair of the ASNC Education Committee. I'm pleased to co-host this episode with my colleague, Dr. Talal Alnabelsi, who will introduce himself. Talal.
Hi, everyone. Thank you for having me. My name is Talal Alnabelsi, and I am one of the nuclear cardiologists and imagers at the University of Kentucky and an LDP member. Pleasure to be here.
Thank you, Talal. If you have attended a major cardiology conference or read through a main scientific journal recently, you must have come across some of the controversies about the Schema Trial. And you must have read or heard something about how this trial did or did not change our practice when it comes to evaluating patients with chest pain and stable coronary artery disease. Tonight, we're going to discuss the implications of a Schema Trial and discuss and talk about the shockwaves it caused in the imaging community. For this conversation, we have no one other than Dr. Tim Bateman, who will be our host for this episode. And it gives me a great pleasure to introduce my mentor, Dr. Tim Bateman. Dr. Bateman.
Well, thanks, Firas. For those of you who don't know, my name is Tim Bateman. I'm co-director of cardiovascular radiologic imaging here at the Mid-America Heart Institute in Kansas City and a professor of medicine at University of Missouri, Kansas City.
Excellent. And now that we know everybody in this episode, Tim, why don't you start off by giving us a high-level overview about a Schema Trial, particularly as it pertains to the imaging requirements to be enrolled in this study?
Yeah, thanks very much, Firas, and thanks for inviting me to comment on this important trial in relation to nuclear cardiology. So, as you know, it was a long study. It enrolled patients from 2012 to 2018. The major publication was in the spring of 2020. There have been many subsequent publications based on sub-analyses, opinions, counter-opinions. So by now we've got a pretty good sense of its strengths and its weaknesses and its impact with regard to the management of patients who have abnormal function test results suggestive of ischemic heart disease. The trial was actually quite small. Given the number of years it went on, it included just over 5,000 stable patients with at least a moderate amount of ischemia on a functional test. So any of SPECT, echo, cardiac MR, or an ECG treadmill test qualified. Eligible patients were randomized 1-to-1 to either an initial conservative strategy of optimal medical therapy alone, and angiography if medical therapy failed, or to coronary angiography and as much revascularization as possible. The primary outcomes were several, but a composite of death from cardiovascular causes, myocardial infarction, or hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. The specific test result criteria for enrollment were as follows. For SPECT, there needed to be one or more reversible perfusion defects affecting at least 10% of the left ventricle. For stress echo or CMR, at least 3 out of 16 segments had to have developed a new abnormality. For an ECG treadmill test, there needed to be an exercise-induced chest pain and specific ST segment criteria that was a bit different based on the level of exercise performed. Interestingly, the only criterion for inclusion was an ischemic test result. That's an important point, and we're going to talk about that later. Well, there were 28 specific exclusionary criteria. The key exclusions were an EF less than 35%, recent revascularization, symptoms that were worsening, and GFR less than 30. The study showed no major differences in outcomes measures between optimal medical management versus revascularization. However, the study did show that revascularization reduced symptoms more than did medical management, that revascularization reduced the incidence of subsequent spontaneous myocardial infarctions, and revascularization was more effective if complete revascularization was able to be achieved.
Great, great. So, Tim, you mentioned a wide range of non-invasive modalities as part of the inclusion criteria. So, how did that affect the trial population, and in your opinion, how did it affect the results?
Yeah, that's a great question. So one needs to remember that this was not designed to be an imaging study. Okay, it was designed to evaluate optimal medical management versus revascularization for patients believed to have at least moderate amounts of ischemia on stress testing. So if inclusion of a wide range of non-invasive modalities influenced the findings in this study, it would be because the modalities did not provide the appropriate target population of patients. This is likely an important oversight of this trial's design. To be sure that the enrolled patients really were correct demands that the imaging findings are accurate. Accuracy, in turn, is influenced by the intrinsic capability of each modality when it's performing at its best, real-world equipment performance, how well in the real world does this stuff work, local interpreter expertise is another issue, influence of the report, the report can obviously steer patients and referring physician decision making, and referring physician confidence in the results. Quality control of the data may also be an issue because this was not an imaging study. It was intended that a core lab would confirm that the criteria for ischemia was met and the study was of high quality, but the slow recruitment led to dropping this requirement. Initial function testing for patients with suspected ischemic heart disease is used much more frequently in the United States in comparison to practice patterns in other countries around the world. Referral to coronary angiography in the US is common when functional tests demonstrate high-risk features. The investigators needed to mitigate the likelihood that they would be unlikely to enroll the target population for this study in the US alone and based on only one modality. Therefore, the study was carried out in more than 300 testing sites in 57 different countries and using different modalities, and within each modality, of course, a large array of different equipment.
Mm-hmm. Mm-hmm.
Even then, enrollment was slower than anticipated. For funding reasons, the study was terminated earlier than planned, treadmill testing needed to be added, and the enrolled patients had far fewer events than was anticipated. So, within each of the modalities used to identify patients with at least moderate ischemia, there are a whole bunch of nuances, and there's not time to go through each modality. But if we just talk about stress myocardial perfusion imaging as a case in point, state-of-the-art MPI was not a requirement for this study. So, for example, there was an insignificant contribution from either PET or attenuation-corrected SPECT. It's highly likely that the SPECT data was affected by attenuation artifacts, so that, on the whole, the amount of ischemia could easily be exaggerated. It is interesting also that coronary CTA, that has enormous use outside of the United States for identifying patients with at least moderate disease burden, and hence selection for potential revascularization, was excluded as a primary modality for identifying eligible patients. Rather, CTA was used as a second test, a gold standard, so to speak, to confirm presence of at least one deemed significant lesion and to exclude left main disease. So enrollment then required not one but two imaging tests, the clinically performed test, but also a coronary CTA. So this adds an artificial bias into enrollment eligibility that literally never exists in daily clinical practice. So my thought with respect to your question then is this was a randomized therapy study and not an imaging study. but the study conclusions are heavily dependent on the enrolled subjects. And I do believe the study findings are weakened by many aspects of study selection, of subject selection, influenced by the nuances of each of the many modalities and their performances around the world.
That's great.
This is very, very useful and a really nuanced take on the clinical trial enrollment criteria. Tim, the next question is probably one of the commonly cited consequences of ischemia on the practice of nuclear cardiology. Some called into question the validity or the relevance of the concept of ischemia testing paradigm, since the ischemic burden in this trial was not a modifier of treatment effect. Patients with mild ischemia derived similar benefit to those with moderate ischemia or severe ischemia. What are your thoughts about that?
Yeah, again, another very provocative question. So there's so much data linking CAD burden to outcomes, and for selected patients linking revascularization to improved outcomes, that I certainly don't think that testing for high-risk patients is going to be affected at all. The ischemia trial was not putting ischemia testing on trial, but was interrogating medical versus invasive management for patients with a predefined amount of ischemia. It's important to focus on study design and endpoints and not on artificial extrapolations that would require a completely different study design. As already mentioned, the major concern with the ischemia trial is what kind of patient did it enroll, whether it actually enrolled its target population, and is the paradigm of risk so entrenched in practice worldwide that there was a pre-selection bias in favor of low-risk patients. There are some findings of the ischemia trial that are surprising and frankly hard to accept. For example, the burden of coronary disease has been shown repeatedly over decades using all modalities, invasive and non-invasive, to be a determinant of outcome. So why was this not shown in the ischemia trial? Why in the ischemia trial did subjects with the largest degrees of ischemia do no worse in either arm than did subjects with lesser degrees of ischemia? Unless there is either a quality control issue with the imaging findings or an equipoise issue such that higher risk patients were not enrolled. The ischemia trial results conflict with a very rich MPI literature, as well as with other modalities, derived from multiple centers of excellence, showing that patients with extensive ischemia benefit from early referral to revascularization. So one has to question how the ischemia trial results could be so different. I suspect that the ischemia trial is not looking at the science linking ischemia with prognosis, but is looking at the real world of testing in which many of the subjects likely had less disease than expected. There is no good reason with state-of-the-art stress imaging that there would not be a tight correlation between ischemia and burden of coronary disease, as has been shown in so many published studies. There are some important aspects of the trial that make it unrepresentative of real-world ischemia testing. First, patients were not, very important point here, patients were not pre-selected with respect to their histories. Okay, it was simply, we do not know the clinical situations of included patients. For example, they did not need to have symptoms, and it turned out that 40% of enrolled patients were completely asymptomatic. So who were these asymptomatic patients, and why were they being tested? How many included patients had ischemic abnormalities on prior function testing and were being chronically managed medically and were doing well? Second, patients underwent 2 tests, as we've already talked about, and this tilts the enrollment criteria artificially. Third, all patients were placed on optimized medical therapy and were rigidly followed for compliance with their medicines. Medicines, in fact, were offered for free. This is totally unrealistic in clinical practice. The comparator, revascularization, was not required to adhere to any type of proficiency standard. Very different than the medication standard. Fourth, enrollment was low, and presumably this is due to equipoise issues. The study enrollment goal had to be reduced by more than 30%. Outcomes needed to be adjusted. Treadmill testing needed to be introduced. If clinicians were only enrolling patients they believed were at low risk and were not enrolling others due to community standards of care, the trial's value is greatly reduced. I wanted also to mention that with most of these modalities, interpreters are aware of identifiers of higher risk beyond the study criteria of just a perfusion defect or a new wall motion abnormality. For example, a left ventricle that dilates on stress testing, or an EF that falls from rest EF on stress testing. This information has not been made available. So one wonders if there were a sufficient number of these patients enrolled to know whether those with true ischemic benefits, true ischemic defects benefited from revascularization, or if in fact there weren't enough patients like that were even included in the ischemia trial. I think lastly, PET data over the past few decades has been showing a change in the phenotype of CAD that we're all seeing, with patients living much longer with their ischemic risk factors and developing a different type of disease with a lot more diffuse disease in the epicardium, as well as small vessel disease and microvascular disease. So how many of the enrolled patients had more than just localized flow-limiting stenosis, and really, in fact, should have been excluded from the study because one wouldn't have anticipated that something like angioplasty of a single lesion or even bypassing a lesion would be helpful. So in summary, with respect to this provocative question, I don't think the ischemia trial does or should have implications for ischemia testing to identify high-risk patients who might benefit from an invasive intervention. But thanks for that great question.
Yeah, I mean, these are very, very important points that you make. So I guess to put it into context, how do you treat these patients, or what's the evidence-based approach in treating patients with symptoms, chest pain or dyspnea, and evidence of ischemia on non-invasive testing?
Well, I think the most important message to come from the ischemia trial is that its results are confirmatory of the repeated findings from large single-center studies. And that is that patients who have many patients who have a moderate amount of ischemia can be successfully managed medically. We've known that. These studies included virtually all patients without the constraints about exclusion criteria as in the ischemia trial. In my opinion, clinicians need to consider all the strengths and limitations of retrospective studies and the strengths and limitations of prospective randomized controlled studies. The best evidence in terms of clinical practice is where there's overlap agreement between these two approaches, and the least convincing is where the two findings diverge. Okay, this simply reflects the reality that neither approach is without flaws. So the two approaches agree as follows. Many patients with moderate degrees of reversible changes on functional testing can be safely managed medically, provided that they are willing and able to comply with best preventative care. Patients with moderate amounts of ischemia who remain symptomatic will have health status benefits with revascularization, and best results from revascularization will depend on completeness of revascularization. So that's great. The two approaches disagree as follows. So increasing amounts of ischemia confer greater risk in virtually all functional test reports over the past 40 years. This was not seen in the ischemia trial. A larger disease burden has been associated with higher risk and benefit from revascularization in virtually all prior studies, but not so in the ischemia trial. and patients with non-perfusion markers of high risk are at higher risk. The ischemia trial needs to analyze this important subset. So neither approach has resolved how to handle patients who cannot or will not adopt optimal medical therapy, such as quit smoking and get their diabetes under control, etc. And very important, the reality, patient preference is another important thing. A patient who has angina once a month might be so bothered by those uncommon events that they prefer revascularization to ongoing status quo, despite a study that suggests that only those with frequent angina will benefit. And most importantly, how do the ischemia trial results inform those sites using state-of-the-art functional testing modalities, such as attenuation-corrected SPECT, CZT SPECT, and PET? So I would conclude that the ischemia trial still leaves many unanswered questions.
Tim, has the ischemia trial changed your practice in managing patients with stable symptoms, chest pain or shortness of breath? And if it did, how so?
I think the major thing that we have changed is in our reports. Our reports have been evolving to infer different degrees of risk in relation to more than just the size of a perfusion defect. For example, we might say that there is an ischemic abnormality involving 10% of the left ventricle. However, LVEF at rest is 56% and its stress rises normally to 64%. There is no transient ischemic dilation. Myocardial blood flow is normal. The patient is minimally symptomatic. You know, in other words, trying to make it more clear that we think that even though there's a moderate perfusion defect, that this indeed is a lower risk patient. One other interesting thing we have changed is that all patients undergoing MPI testing now fill out an abbreviated Seattle Anginal Questionnaire prior to testing. So this gives the interpreter an insight to the patient's health status and a potential link to the significance of a perfusion defect. It's interesting how this patient perception is different from the referring physician's indications for testing. You know, often the only thing we get from the physician is the patient is having chest pain, but that might have been a singular episode of chest pain that the patient has recalled to the physician. So health status is beginning to evolve into a metric that we include our reports, so that when a referring physician sees a moderate reversible perfusion defect, he or she also sees just how symptomatic the patient self-reports.
Yep, that's very helpful. So I guess if we have to redo the trial, so if we had to redo the ischemia trial, what changes would you make to the enrollment criteria to ensure that we have meaningful results that impact patient care?
Yeah, so the investigators, I think, recognized that they would be facing a major challenge given the massive amount of published data that favored ischemic-driven management decisions. And they tried to overcome this through expanding sites to numerous countries, different modalities. I would argue that they were not successful at overcoming these issues of referral bias. The telltale signs are many, right? They had very, very slow enrollment. The low numbers of enrollment per site relative to known testing volumes is another telltale sign. 40% of patients had no symptoms. You know, wow, that's an interesting group to randomize, isn't it? Much lower incidence of endpoints than predicted. Okay, suggests it's a lower risk population than they were seeking. The endpoints evolved some during the study because of the shortage of appropriate patients. Had to expand into treadmill testing, which was not originally part of the protocol. And most of all, that surprising finding we've talked about, that ischemic burden did not translate into worse outcomes regardless of medical or invasive therapy. So all of this suggests that enrolled patients were much lower risk than their imaging results suggested. In my opinion, the major mistake was regarding patients as imaging results. The most important enrollment criterion and in fact, the only enrollment criterion was at least 10% ischemia. Patients were therefore defined kind of as an image. But there are obviously subsets of patients with moderate ischemia who are at low risk and are easily identified to be at low risk. And clinicians regularly assimilate patient-specific data and imaging results in making decisions about risk. So a few examples of patients likely included, one, there is an apparent moderate-sized perfusion defect anteriorly in the distribution of the left anterior descending coronary artery. The patient has large breasts, and this may be contributing some to the true size of ischemia. I'd probably randomize a patient like that, There is a 12% reversible perfusion defect in the distribution of the known occluded right coronary artery. Well, I might include that patient. There is a 15% reversible perfusion defect in the lateral wall. There are no changes in comparison to prior studies. Well, I might enroll that patient too. But these are all very low risk patients, right? I mean, that's not rocket science. So most referring physicians would have no problem randomizing them. Indeed, the investigators even came around for site visits and encouraged that. So less likely to be included are de novo patients with new symptoms and the finding of a moderate to large reversible defect, patients with already known CAD who now have a new abnormality, patients with concerning symptoms, patients who have new ischemia, are scared and don't want to be in a research study, patients whose study interpretation uses words like large or higher risk or with transient ischemic dilation. So not pre-specifying inclusion criteria beyond the perfusion defect makes the results not clearly generalizable and is a major problem with trying to translate the study into actionable changes in how clinicians respond to imaging results. So in my thought, I don't think I would recommend redoing the ischemia trial all over again. I think rather the ischemia trial has raised many important questions, and I would advocate that exploration through targeted studies of these selected questions would be the way to go. And I would favor furthermore a modality-specific focus. Given the way the market is moving, mostly PET-based or at least attenuation-corrected high-quality SPECT, I think that medical management and invasive therapies need to be balanced, either both real-world or both optimized, but not imbalanced between the two. I would also focus on the new realization that many patients with ischemia have disease that is simply not amenable to revascularization, even though there may be a localized stenosis, such as those with diffuse epicardial disease, small vessel disease, and so forth. So that's kind of my kind of final thoughts on the ischemia trial. It's an important trial. I'm glad it was done. I don't really think it's going to have any major implications with respect to the field of nuclear cardiology.
Thank you so much. This was such a rich conversation, and you gave us a deep dive into the intricacies of ischemia trial and some of the challenges and the opportunities that came about with this important trial. I would like to thank you, Tim, for your time and your expert input on this trial. I would like to thank Talal also for his great contributions and questions. And lastly, I would like to thank the audience for participating in this session, and I hope you find it worth your time. And until we meet in another episode of the ASNC interview series, I wish you all take care and be safe.
Thank you.
Thanks.